So good morning. I have to say that my talk is going to be a lot different than James because I didn't have the confidence that I could cover the amount of material that you covered in that short period of time. He's obviously been living and breathing this in a really sophisticated environment, and it's impressive to see all that's been put together at Memorial Sloan Kettering. I will say that what really helped me there was there's this tendency, I think, to feel like the grass is always greener on the other side. So living in the Mosaiq environment, I'm very mindful of all the things that I wish that were and that were different. It was at least encouraging to me to hear that you deal with some of the same things. We all have the same problems, whether it's getting our physicians to read their emails or to accept tasks or to complete their plans. It's good for me to know that we're not the only ones suffering with that. So, as I say, my talk is going to be a little bit different because I wasn't convinced that I could talk about a lot of the details and the various permutations. So maybe it's a higher level talk, but hopefully it'll be informative. It'll involve more questions perhaps than answers, but I hope it makes us think about some things that are going on. And as Brian alluded, I've been around first Impact and now Elekta Mosaiq for over 20 years, and hopefully that gives some perspective about where we've come from and where we've gone to, and I'll try and talk about that today. And you can see that from the title. Certainly I'll talk about some clinical experience with Mosaiq, but I also see as soon as we start talking about clinical experience, we start talking about challenges and workarounds, and as soon as we start talking about that, I think the notion of the so-called mixed environment comes up. And let me talk about what I mean by a mixed environment. And by that I mean an environment where the record and verify system is not manufactured by the same vendor as your Linux and or your treatment planning systems. And obviously being on the other side of this, or being in the mixed environment, I'm always imagining that everything works smoothly and perfectly on the other side. And again, it was encouraging for me to hear James talk about the fact that you still have to use PDFs in some cases, you do use documents, and we still have a ways to go on both sides. The good news is I think there's incredible progress that's being made. So an example of that mixed environment is, as I said, where I live, which is using Elekta's Mosaiq product to manage variant linear accelerators, or Mosaiq with the Eclipse treatment planning system. And that's my environment. I have mostly variant linear accelerators. I have one Siemens Artiste, and I use Eclipse. So in covering this today, I'm going to give a very brief overview chronology of kind of where we came from and where we've come to be. I think that'll be relevant when we start to talk about some of the questions I want to pose. And then, of course, the perceived advantages and disadvantages of the single vendor environment versus that of the mixed vendor environment. And I emphasize perceived here because I want to acknowledge up front that these are my perceptions from talking with friends and colleagues. I'm confident that many of you might share these perceptions, but I also know that some of you may disagree, so I'll make that disclaimer up front. I'll wrap up with some questions that I think are relevant for us to think about and some conclusions. So my brief chronology, I found this paper from Radhi Mohan at Memorial Sloan Kettering and saw that the record and verify terminology was starting to be used, and this in-house version was being published on in the early 80s. In the late 80s to early 90s, Varian had a product called RMS and had some basic functionality. When I entered graduate school in 1990 at the University of Texas Health Science Center, it was there. I remember seeing it. It was kind of a DOS-like environment. What I mainly remember was when we moved forward to the next iteration, that it was as you would expect at that time, a proprietary database, and so I remember leaving all our data behind. There wasn't any way to port it forward, so we've obviously come a long way since then. In the early 90s, you may know that Impact started in the early 90s, had a product called Access or Multi-Access, and many of you may know the story of three Varian engineers that had the idea for much broader applications for the record and verify approach, and as the story goes, they talked to Varian about that. Varian didn't feel like that they were ready to emphasize resources on that at that point, so these guys quit their job and lived off their credit cards and worked out of that garage. started the product, and as I said, broader application and a vision of running the entire department's operations, enhanced verify and record, but also scheduling and billing. And they became the market leader very quickly because, as we've seen, that's the direction that this field wanted to go, was having software that helped us across all aspects of our operations. In 1993, as a mid-level graduate student, I was put in charge of installing an early version of Impact at our cancer center. And in interest of full disclosure, that's where I met my wife. She came and trained me and hasn't stopped, actually. She was an early Impact employee. So I thought it might be interesting to remember, if we can remember back that far, what the computer environment looked like in 1991. And we were having discussions about whether we should be using a token ring topology, a star topology for our networks, or whether this thing called Ethernet was going to work. We had 386 computers that had megabytes of memory available to them. And I found this paper by Mike Herman that was characterizing the server characteristics. And so we could have megabytes of RAM at that point, and if we had a really powerful server, we might have gigabytes of hard disk storage space. So a really different environment from today. In 1993, Varian's Veris came around, and you've just heard a lot about the whole Varian environment. I'm not going to spend time on that. That was basically Varian's counter to multi-access. In June 2000, Varian announced plans to buy Impact Medical Systems, but later that year the Justice Department blocked that purchase because of, as I understand it, concerns over Varian's already very strong position in the LINAC market. In 2004, Impact announced the product Mosaiq and the vision of a continually broadening application and use of what was a record and verify only system to broaden out into OIS or EMR, whatever we want to call it, with computerized physician order entry, image management, all of that stuff. In 2005, Varian Aria continued that vision now with Varian embracing that of the comprehensive approach to help us manage the entire department. In 2005, Elekta decided that they would buy Impact. And then I'm going to lump 2005 to present in just one slide and say that from my perspective, Impact's Mosaiq, or Elekta's Mosaiq, has continued to evolve a feature set and transition to an Elekta-run product. Varian has focused, as I think we would agree, significant development commitment into Aria. And in my opinion, recently Aria has emerged and caught up as that very formidable competitor to Mosaiq. So I'm kind of laying the landscape for today. Today, Varian still has the largest number of LINACs in place in the U.S., followed by Elekta, Siemens, and Accuray. Aria has been increasing its OIS market share due to the significant improvements in its feature set and functionality. And because of Impact's initial dominance of the R&V market in radiation oncology, there still exists a large contingent of centers who still use Mosaiq to run Varian LINACs. And that's the category that I fall into, and hopefully the context that I'm setting. So in case you're wondering what's the right decision, continue to use Mosaiq to run our all Varian LINAC operations, or mixed LINAC vendor operations, or switch to Aria. I don't know the answer to that question. Hopefully we'll shed a little bit of light on some pros and cons on both sides of that coin, and I'll pose some questions that I think should help shape our decision making. But obviously there's not a single right answer to that question, and it'll be shaped by nuances unique to each of your environments. So that's a quick chronology. Let's look at both sides of the coin, maybe starting with the single vendor environment. And I guess when I talk about an advantage of the single vendor environment, I'm going to be by default also talking about a perceived disadvantage of the mixed vendor environment. So single vendor, one advantage I might say is we would naturally anticipate smoother, more efficient interaction or communication between the OIS and, for instance, the treatment planning system. And we just talked about the various workflows that go into this. An example is with Elekta's Mosaiq and in my situation, Varian's Eclipse treatment planning system. So let's talk just briefly about the prescription and plan approval. And this is an overview of our workflow, which transitioned from paperless several years back. In our particular instance, the physician will enter that initial intended prescription that obviously can change as we go along. In this particular case, the plan was designated as a static gantry IMRT plan. And then based on conversation, the way it typically works in our clinic between the dosimetrist and physician at simulation, the dosimetrist is going to generate the treatment plan in Eclipse. And this is characterized by the technique, energy, machine, etc. Interestingly, many times the dosimetrist will decide to run more than one plan, and so this prescription may need to be changed with regard to the technique that's being used. The physician will review and decide which plan they like, and in this example case, for instance, they've chosen VMAT. When the plan is complete and the physician meets with and reviews the plan with the dosimetrist, as is often the case for us, there can be a verbal approval of the plan. At that point, the dosimetrist, in our instance in Mosaiq, will lock the plan from being changed by doing a form of approval. So at that point, the dosimetrist exports the plan as a PDF from Eclipse to a network folder, and as James was describing earlier, for some of these other workflows, similar to theirs, in that the dosimetrist will then use Mosaiq to import the PDF into Mosaiq, and then the physician approves this PDF document is basically how it works in our environment. And this is our official plan approval. Obviously, there's some extra steps, and this is potentially problematic. The fact that the plan changed to VMAT, when the physician is reviewing and looking at a PDF as their representation of that plan, they either have to remember which plan they chose, or they have to page through the pages of the PDF and confirm that they're making sure that they're approving the same plan that they verbally approved with the dosimetrist. So I'm not going to, because James did a great job of going through this, I'm going to kind of jump ahead. There are obviously various ways to link plans to treatment plans to prescriptions, and he did a great job of showing us what that looks like. In short, there's some extra steps that can be involved in this process, and some of the inconvenience in Mosaiq can be eliminated by a new module called Evaluate. And Evaluate allows a Mosaiq user to open a DICOM plan from any planning system in Mosaiq. So in that environment, and we expect to have Evaluate soon, the dosimetrist would export the possible treatment plans from Eclipse to Mosaiq for the MD to review. The plans show up on the MD's work list, and they can review those plans and decide which one they like. And the key is that they're interfacing with the plan in a fashion similar to the way they would in Eclipse, meaning that they can look at isodose distributions and renderings, 3D renderings, DVHs. There's a neat feature where physicians can have site-specific criteria that are defined, and then according to whether those criteria are satisfied, they can get green checks and red X's to emphasize where things were not satisfied. And then they can approve within Mosaiq. There's plan comparison tools for overlay of DVH and side-by-side, etc. So I think that will help to alleviate some of the inconvenience of the way we're having to do things right now. So we're talking about perceived advantages and disadvantages of the single vendor solution. Another one that I would propose that we would expect would be a lack of feature lag. And let me describe what I mean by that. And that's, to my thinking, the delay in one vendor's newly released functionality becoming available or enabled by the other vendor. An example is Varian has a 6 degree of freedom robotic couch. They might release that before Mosaiq can fully support that couch. Cooperation between the vendors is obviously required for that to be efficient, and I think we'd be naive to think that cooperation was always 100%. But also we need to realize that it's about resource allocation. And Electum may be prioritizing development resources to implement a new feature on their own LINAC versus hurrying to support that Varian's new feature. it stands to reason that a particular vendor can more easily introduce innovative new features on their own LINAC if it's supported by their own OIS, versus Mosaiq having to scramble to support that new variant LINAC feature. And the same, of course, is true for Electa more easily supporting their new LINAC features in Mosaiq for their Versa HD. So let's look at a couple of examples of what I call feature lag. The TrueBeam LINAC is capable of something called on-demand imaging, which allows for acquisition of image guidance imaging that was not planned or scheduled on the treatment calendar. The physician may show up today and say, hey, I want to get a cone beam CT. It's on-the-fly imaging at the machine. On-demand supports that. We happen to be at Mosaiq version 2.4. Version 2.62 is the most recent version, and we'll be upgrading to that shortly. But in version 2.4, if you acquire a cone beam CT on demand for Mosaiq 2.4, the cone beam CT will transfer back to Mosaiq but will not be associated with the reference CT. If you acquire a planar image on demand, the planar image will transfer back, but the DRR will not. If you acquire TrueBeam triggered imaging, which is a form of imaging that will allow you, for instance, on an ARC delivery, to trigger images every so many monitor units or degrees of angle, only the last image will transfer back, not the whole set of triggered images. In ARIA, we would expect this to work because it's a variant product. These limitations may well be fixed in version 2.62, but they're examples of that lag that I'm referring to. We'll know in a couple of weeks. Another example of a feature lag situation is when the TrueBeam takes a cone beam CT, it automatically centers the couch to ensure clearance for LINAC rotation. When the imaging is done, it returns the couch automatically to the treatment isocenter location. A problem in 2.4 is when it receives the image guidance couch position change from TrueBeam, these numbers are extremely large, and instead of being a handful of millimeters or a centimeter, as we might expect for the image-guided shifts, they have been combined with the couch centering shift, so these numbers are really large. And this is obviously a communication issue between TrueBeam and Mosaiq, and we expect this to be fixed in a future version as well. Each of these examples, on-demand imaging and couch coordinates, can be dealt with or worked around in Mosaiq. They just involve some extra steps and some understanding. For on-demand, we just manually associate or import the reference image. For that couch value situation, we have to understand that what Mosaiq flags as tolerance table overrides are not real overrides. But these are inconvenient and inefficient, and Mosaiq will eventually catch up with these features and the problem will go away. There's some lag time. So those are some examples. James talked about the elaborate process that we have to go through for upgrades. These previous examples I've given you are typically eventually fixed by an upgrade. So how frequently should we upgrade? Do we want to upgrade as soon as the vendor brings out a new version? We happen to have skipped Mosaiq 2.5 because it actually introduced some problems with functionality on our Siemens Artiste. We also need to remember that multiple publications say that careful QA of the R&D system must occur whenever changes are made to the software or the overall process. And as James alluded to earlier, that's a lot of work, and it could cause us to decide to choose to delay and only do key updates as they have relevance for us. So I think this will be our first Sam's question. Multiple publications, including TG142 on QA of medical linear accelerators, suggest that careful QA of the R&D system occur whenever changes are made to the software or the overall process, true or false. Yeah, so I kept it easy enough. That's good. So obviously the answer is true. So we've talked about a chronology of kind of where we came from and where we are today. We've talked about the single vendor environment, perhaps perceived advantages of that. Let's talk about the so-called mixed environment now. One So one thing that I think that people have been with Mosaiq as long as I have would say that there's a reason that Mosaiq has been the market leader for a long time. They led the way in implementing new and broader applications and envisioning a broader way to use the R&V system. Historically there's a legacy of excellent customer service. Some of the features, innovative, valuable features, or things like quality checklists, and we saw great examples of a similar construct in ARIA for this. Mosaiq quality checklists are groups of procedures, tasks, or activities. The department uses these QCLs to assign and monitor tasks, and they can be used to remind staff of tasks that need to be completed and can help us monitor their status. And we saw examples in the previous talk from that. That's a super useful thing that has found its way into broadening the use of the record and verify system. All of the individual tasks associated with a large process in Mosaiq can be distributed in one step to the to-do lists of individuals involved in the process. And the examples we saw earlier, and I think is a good example, is of the treatment, the process by which we generate the treatment plan. So the dosimetrist has the task to import the CT from CT Sim, the physician has to do the contours, dosimetrists do the plan, etc. So let's do another Sam's question. Which of the following are true? A user work list, called a quality checklist in Mosaiq, is a list of to-do items for a particular user. A department can use QCLs to assign and monitor tasks. All of the individual tasks associated with a large process can be distributed to multiple users in a single step. None of the above or all of the above. All right, so we're all still answering the easy questions. So a limitation of that approach is that these steps are distributed to users' to-do lists all at once, and even though some can't be completed until the preceding step is done, and that's where something called scripting can come in. By scripting, I mean pre-built computerized automation of a multiple-step workflow by automatically queuing sequential steps of the process on a user work list. Mosaiq's product is called IQ Scripts, and it can be used to cause each to-do item to be put on work lists only once the preceding step is complete. It automatically sequences the tasks in proper order. And as I said, these are pre-built procedures that flow using simple scripting. And once a task is completed in the chain, that task can disappear off a user's work list, and then the next item in the list can appear on the next person's work list. And obviously, a good example, as we've said, is the treatment planning process can be outlined and queued up in this way. So let's do our last Sam's question for me. Scripting in the radiation oncology EMR environment refers to the process of writing multiple prescriptions efficiently in a computerized environment, the process of reviewing the patient workflow, pre-built computerized automation of a multiple-step workflow by automatically queuing sequential steps of the process. 4, the process of reading from a checklist when performing a complex SBRT workflow. And 5, specification of the chemotherapy drug prescription. Brian, is there an award for the easiest questions? So obviously the answer, we had 90% there, and number 3 is that computerized automation. So other perceived advantages of that mixed environment. I think a lot of people who've been with Mosaiq for a long time recognize that they've been around and been leading the market for a long time and introduced a lot of new features. I think this is an important one. There's also a legacy from the impact days of Mosaiq working well with other vendors' products. And this is highly valued by a lot of users. I can say that it's valued by me in that mixed environment. So that's our quick look at both sides of that coin. Let's transition into some questions that I want to say are questions that I don't know the answer to, but I think they're relevant for us in thinking about what to do going forward and where this field is going forward. So Electa now owns Impact, which had a legacy of supporting all vendors' equipment well. Now that Electa is owning them, will they continue this commitment? I think it's only natural for us to acknowledge that, like Varian, Electa will commit significant resources to making their OIS fully functional with their own Linacs. Are the days of strong support for other vendors' equipment gone now that both of the leading OISs are owned by a Linac manufacturer? I think that's something I'm wondering about going forward and will affect my decision on what I do going forward. Interestingly, I learned just in the past few weeks that Research has announced that they're going to bring a product to market in late 2017 called RayCare. They were kind enough to send me 3 slides. They wanted me to be very clear that this is not available for purchase yet. But if you look at the slides, a few things jump out at us. They feel strongly that adaptive radiation therapy is going to be important. And for that to work, that's going to have to be rolled into the OIS. The second slide that they sent caught my attention because it was titled Support for Mixed Treatment Delivery Environments. So that's obviously something that they think is going to be important in collaborating with multiple hardware vendors. So if we look at a summary, they're saying that this new product will focus on support for mixed treatment delivery environments, collaboration with hardware vendors, and treatment adaptation. So that raises the question for me, is Research looking to position itself to try and fill that role that was held by Impact when it was independent as a Linac neutral OIS vendor who works equally well with all vendors? Sounds like they may. Some other questions that I thought of going forward is Electa's a really large company compared to Impact. Can they continue that strong reputation that folks like me that have been loyal to Impact for a long time had for that customer service? I think that's a challenge for a big company. I wonder if Varian is going to grow its level of ARIA support for Electa Linacs. And with Siemens out of the Linac business, some say that Accuray is that third Linac vendor. They certainly have plenty of units worldwide. Will Varian, ARIA, and or Electa Mosaiq grow their support for Accuray's linear accelerators? Other questions relative to this mixed environment. Are we headed for days when mixed environments are not practical anymore because the vendors will do such a great job of making everything work really well within their product's environment? Or will there always be a desire amongst customers to choose products from multiple Linac vendors? Will there always be mixed environments, or will we migrate away from that where we'll all have products from one particular vendor? So these are my conclusions from my perspective. The Mosaiq environment continues as a strong player in the market. Many of the Mosaiq users are longtime users like me who chose Mosaiq when they were the clear market leader. ARIA is now widely regarded as an equal competitor, and so we have choices now, and competition's a good thing from the customer perspective. Many of the Mosaiq users are these mixed environment users who have Linac and treatment planning systems from vendors other than Electa. Existing in a so-called mixed environment, I think we've seen today, means that there are some compromises required, such as dealing with workarounds and feature lag on other vendors' equipment. Some will see this as a major inconvenience and justification for considering a switch. Others will see it as small relative to the advantage of remaining with a product that has a long history and with a product that has supported that mixed environment. The same users might argue that many of us will always exist in a mixed environment because we'll always want to be able to select the best Linac and deal on the market at that time. At the end of the day, as I said at the beginning, it's an individual decision based on nuances unique to your environment. There's not a single right answer in the end. So I would say you can pick your poison, or maybe put another way, you can pay your money and take your chances. And I'll stop right there. Thank you.
I especially appreciate the history about the early impact days of the Bill share that. And then the other thing I really appreciate is Bill wears two hats. One is the chief of physics, the other is the director of the radiation oncology. I think that's why Bill have a lot of this discussion about whether are we going to a single vendor or mixed environment, and lots of decisions we need to make. And I wish sometime I have the other hat and then can have more input to the administrators of the decisions and the implications on this choice and the selections. But I don't know if that's a good hat or a more trouble hat, whatever. But anyway, so that we cover pretty much our most external beams recording verify system. And then to complete the session, and then we are going to move on to brachytherapy and NRC regulations in this electronic charting. And for that, we have Dr. Sonia Dietrich, and she is the associate professor at UC Davis, and she's also the co-director at of their residency program. And also Sonia is also a task group member of the TG 262. And welcome, Sonia.